morning all. Myself Dr. Bhavik Champaneri. Today I am going to talk about fetal circulation and its transition to neonatal circulation. So first, what's the basic difference? You have to understand what is the difference between adult circulation and fetal circulation. So first of all, adult circulation is called a series circulation. So what is happening? The circulation of blood is in a series. The systemic venous return goes into right atrium, then it goes to right ventricle, then through pulmonary artery goes to lung, get oxygenated, and it comes back to left atrium, left ventricle, and it supplies the entire body. But it's not so in case of fetus. Fetal circulation is called parallel circulation. Why it's parallel? Because the ventricles, both right ventricle and left ventricle, act simultaneously and it has different role. Right ventricle supplies blood with low oxygen content to the lower part of the body, and the left ventricle supplies blood with a higher oxygen content to the more important organs like brain, upper part of body, coronaries, like that. So that's the basic difference, that fetal circulation, it's a parallel circulation. So it's important to understand the various structures which are responsible for maintaining fetal circulation, and first is placenta. So placenta is very important when we are talking about fetal circulation. The gas exchange happens at the level of placenta and not at the level of lungs, because lungs are under expanded and the gas exchange does not happen at the level of lung. Next is umbilical cord, which has one umbilical vein and two umbilical arteries. Third is ductus venosus, foramen ovale, and ductus arteriosus. So these are the important structures which maintain fetal circulation, and any hamper at this 4 point may affect fetal circulation and fetal life as well. So when we are talking about fetal circulation, it's covered in 4 topics like course of the blood, oxygen saturation in various heart structures, pressure in heart chambers, and cardiac output. So talking about course of the blood, so this is a diagram which shows the circulation of the blood circulation in fetal life. As you can see, this is a placenta where gas exchange happens. Blood gets oxygenated. That oxygenated blood goes through umbilical vein, as here you can see. Through umbilical vein it enters into ductus venosus. From ductus venosus it enters into IVC, and it is preferentially directed towards left atrium, left ventricle, and that oxygenated blood goes to brain, coronaries, and upper part of the body. At the same time, the blood with low oxygen content from systemic veins enter through tricuspid valve into right ventricle, and then it goes through pulmonary artery, and through ductus arteriosus it supplies descending thoracic aorta, and through these 2 umbilical arteries it goes back into placenta for oxygenation. So this is a chart showing the circulation of oxygenated blood or blood with higher oxygen content. From placenta it goes through umbilical vein. From umbilical vein it goes through ductus venosus and it enters left hepatic vein and IVC, inferior vena cava. From inferior vena cava the stream of blood is preferentially directed into foramen ovale and it enters into left atrium and left ventricle. Very small amount of blood from umbilical vein enters into right ventricle, that is around 5% of volume. From left ventricle it goes into ascending aorta and supplies coronaries, brain, and upper limbs, and very small amount of blood goes into DTA, goes into descending thoracic aorta. This is next slide showing the circulation of deoxygenated blood. As you can see, a deoxygenated blood or a blood with low oxygen content from SVC and IVC and right sided hepatic veins, it enter into right atrium and right ventricle, and very small amount only enters into left atrium. From right ventricle through ductus arteriosus, 95% of the blood volume from right ventricle through ductus arteriosus it enters into descending thoracic aorta, and only 5 to 7% of volume only enters into lungs, because the lungs resistance is so high it does not accept any blood. From descending thoracic aorta through umbilical artery it is being supplied again back to placenta, and very minimal amount is supplied to abdominal organs and lower limbs. So this is an anatomy of umbilical vein and ductus venosus, which is important in understanding the fetal circulation. So umbilical vein enters into the liver parenchyma and it joins the portal vein. There is a connection between portal vein and left hepatic vein, which is called a ductus venosus, and this umbilical venous blood is preferentially diverted through umbilical vein into the left hepatic vein and IVC, and this IVC blood is preferentially directed towards foramen oval, and eventually it enters into left atrium and left ventricle, and that is how oxygenated blood is being supplied to brain and coronaries. So talking about oxygen saturation, this is a diagram showing various oxygen saturation or various oxygen content in various parts of fetal body. So as you can see, the red colored structures are the structures which has the highest oxygen saturation, and blue color structures are the structures which has the lowest oxygen saturation. And you can see the left sided heart has the highest oxygen concentration because it has to supply to coronaries as well as brain. So this diagram shows in liver parenchyma the umbilical venous blood is having the highest saturation, and that is around 83%. So the fetus receives the highest amount of the blood with highest saturation is 83%. Then it get mixed with the left hepatic vein, and eventually it becomes a saturation of around 70%, and that enters into left ventricle. It is important to notice that right part of the liver, as you can see here, the right hepatic vein and portal venous saturation is very low. So this low saturation and that explains that right side of the liver has the highest amount of hemopoietic cells when it is compared to left side of or a left lobe of a liver. So that is a reason for large amount of hemopoietic cells found in right lobe of the liver. So this is a diagram showing oxygen saturation and pressures in various chambers of the heart. As you can see, the highest saturation when it enters into heart is around 70%, which is diverted to LA and then LV. So the LV saturation is around 65%, which is being supplied to coronaries and brain. The right sided structure and the systemic blood from superior vena cava and more deoxygenated blood from inferior vena cava enters into right ventricle, where the right ventricle blood saturation is around 55, and it is preferentially diverted through ductus arteriosus into descending thoracic aorta. Now talking about pressors, so it is you should know that this pressure is mentioned in view of intraamniotic pressure. So intraamniotic pressure is taken as a 0 value, and then this value are written here. So it is important that in fetal life both the ventricles as well as both the great arteries are having equal pressures, because there is no because it functions in a parallel fashion and it has a parallel circulation. It supplies eventually aortic eventually it supplies aorta. So the right ventricle and left ventricle has a pressure of around 70, and both great arteries have a pressure of around 70 by 45 with mean of 55 as shown here. Coming next to the cardiac output and its distribution. So again there is a peak in this because postnatal circulation is a series circulation, as I have mentioned earlier. So the cardiac output in postnatal circulation is a volume of blood which flows through heart per minute. So it represents a volume of blood which is being ejected by each ventricle. So right ventricle and left ventricle are ejecting equal amount of blood in postnatal life, but it is not so in fetal circulation. Here actually ventricles are effectively working in a parallel fashion, so output of both ventricles are different. So the cardiac output in fetus is called a combined ventricular output, because the right ventricle and left ventricle has a different output, and combined ventricular output is a sum of the output of right ventricle as well as left ventricle. So the terminology cardiac output is being changed to combined ventricular output when we are talking about a fetal circulation. So this is a diagram showing various amount of combined ventricular output, various proportion of combined ventricular output which is provided by each ventricle. So as you can see here, nearly 70% of combined ventricular output comes from IVC. So nearly 2/3 of combined ventricular output is coming from IVC, and 1/3 comes from superior vena cava. And as you can see here, right ventricle has a 66% of combined ventricular output is being provided by right ventricle, and from that 66% almost all entire cardiac output or a combined ventricular output is diverted through ductus arteriosus into the descending thoracic aorta, and around 5 to 7% of combined ventricular output goes into lungs. When we are talking about left ventricle, the left ventricular combined ventricular output is around 34%. So that means 1/3 of combined ventricular output is from LV and remaining from right ventricle, and this ventricular output goes preferentially into coronaries and upper part of the body. Only small proportion of the blood flows through aortic isthmus into descending thoracic aorta, and that explains why the isthmus of aorta is the smallest in entire aorta. Because the flow across the isthmus is very minimal, and that's why the growth of that isthmus is less as compared to rest of aorta. And this diagram is basically a fetal lamb circulation and fetal lamb combined ventricular output. When we are talking about human fetus, the left ventricle account for 45% of combined ventricular output, because we have a advanced brain and the brain circulation is more, and to provide that the left ventricular output is more in human fetus. So next is cardiac failure in fetus. So it is important that fetus is more prone for cardiac failure, and why? Because the maximal myocardial force provided by myocardium of fetus is very less as compared to adults. The compliance of myocardium is low, excitation contraction coupling is poorly developed, and sympathetic innervation is poor when we are talking about a fetus. And these are the causes of cardiac failure which leads to hydrops, which includes obstructive lesions at the level of foramen ovale or ductus arteriosus, atrioventricular valve regurgitation, high cardiac output state like anemia or twin-to-twin transfusion syndrome, arrhythmias, decreased myocardial function in case of genetic cardiomyopathies. These are the various causes of fetal heart failure which eventually leads to hydrops fetalis. Now comes postnatal transition. So there are certain changes which occur when baby is delivered. So which are those changes? First, immediately when baby is delivered, we clamp umbilical cord. So now placenta is no more a gas exchange mechanism, and that gas exchange function is being diverted to lungs, and there what happens is a closure of ductus arteriosus and foramen ovale after birth. So what changes occur in pulmonary circulation? At first breath of the baby, there is expansion of the lungs. So the pulmonary vascular resistance decreases drastically. There is increased pulmonary blood flow with high PO2, so it leads to prostacyclin secretions which causes further vasodilatation. There is increased circulating nitric oxide by endothelial cells which further causes vasodilatation of pulmonary vasculature, and this leads to gradual regression of muscular layer of pulmonary arteries, and which further leads to decrease in pulmonary vascular resistance by around 1 to 1.5 months of age. The next transition which happens is closure of foramen ovale, and the mechanism is increased pulmonary blood flow. Because of that, the pulmonary venous return is increased. Since pulmonary venous return is increased, LA pressure increases. At the same time, we have clamped umbilical cord, so there is no umbilical venous blood coming to RA, so RA pressure decreases, and decrease in RA pressure and increase in LA pressure eventually causes apposition of septum primum and septum secundum, leading to closure of foramen ovale. Next is closure of ductus arteriosus. Again, the PO2 is increase in circulating blood which causes bradykinin release, which promotes constriction of smooth muscles of ductus arteriosus and eventual closure of ductus arteriosus by 4 to 7 days of life. It is important that whatever structures we have seen in fetal circulation eventually becomes derivatives of fetal vascular structure, and the name is umbilical vein becomes ligamentum teres, umbilical arteries become medial umbilical ligaments, ductus venosus and ductus arteriosus become ligamentum venosum and arteriosum respectively, foramen ovale becomes fossa ovalis. So this finishes the fetal circulation and neonatal transition of fetal circulation. Thank you.